virtual program. So thank you all for watching online. This is called Going the Distance, Sustained Therapies for Ocular Inflammation. Thank you for joining us for today's program. My name is Rishi Singh. I'm the faculty moderator from Cole Institute, Cleveland Clinic in Cleveland, Ohio. I'm joined by my esteemed panelists here in these very large, ultra-seated chairs. I don't know why they're so big. Everything's bigger in Texas, apparently. First, Dr. Carolyn Baumel. She's from Tufts Medical Center in Boston, Massachusetts. Dr. Thomas Albini. He's from the University of Miami, Bascom Palmer in Miami, Florida. And Michael Singer. He's from the Medical Center Ophthalmology Associates in San Antonio, Texas. So thank you all for coming. And we're going to have a great discussion on sustained delivery. Here are our faculty disclosures for today's program. And our program is actually accredited by AKH. And at the end of today's program, you can receive credit for the program hour you're going to receive for CME credit. There's a survey you have to fill out at the end of the program. And you fill that out, and you'll get your credit in the mail afterward. In addition, we have an independent medical education grant from iPoint Pharmaceuticals supporting today's program. Here are our learning objectives for today. And to summarize, we're really going to talk about getting into how we diagnose and treat chronic non-infectious uveitis. How does imaging help us make this diagnosis in our patients? And really how we take the treatment approach. There's a stepwise approach for a lot of our patients. They might start on topical therapy, advance to more additional therapy as time goes on, depending on their chronicity. And we'll talk about how we titrate those therapies and really decide on the patient level what should be done. We'll also talk about both the benefits and the risks of these therapies and how we both balance those risks with our patients. And we'll actually have case discussions. So this is really case-based. We're not going to really talk about slides and look at data. We're really going to have cases, and I've had the panel submit cases for us today for us to review. And I'm going to have each of us comment on these cases as we go along. And again, I mentioned the credit issue. And again, questions and answers. If you have questions on the live program that you're watching, please fill out the question box. We're going to take questions as we go through the entire program today. So please feel free to submit as many questions as you'd like, and we'll get to them through the discussion. All right, so let's start off just talking about sort of the current utilized steroids for non-infectious posterior uveitis. So we have topical agents, prednisolone, non-steroidal agents, dipropionate. We have intravitreal triamcinolone acetonide, which is used off-label for conditions like uveitis, posterior uveitis as well. And the dexamethasone intravitreal implant, which is indicated for the treatment of non-infectious uveitis as well, and also the fluocinolone implant as well. But let's talk about this, Carolyn, a little bit more. You know, how do you decide which steroid to start with on a topical level if you're considering a patient with non-infectious uveitis? And do you migrate to an intravitreal right away or wait on that patient?
Great question, Rishi. I usually, in most of my patients, we start on prednisolone because that's easily accessible. It's covered by most insurances, and most pharmacies have it. But occasionally, you know, we'll use a difluprednate or another steroid. It might be a little bit more of an issue with coverage and going through someone's insurance. I would say that I really try to tailor how I treat my patient to the patient's ability to return for follow-up, to what the disorder is. But I do think that intravitreal steroid implants offer the benefit of taking kind of the compliance from the patient. You know, they don't have to think about putting the drops in, missing drops, and certainly for a serious ocular disease, a serious intraocular inflammation, I will go relatively quickly to intravitreal steroid use. I think we have a lot of experience with that, and I'm sure the other panelists will chime in.
So Tom, you know, one of the differences in Tom's practice and ours is that he actually treats uveitis, and we aren't uveitis trained, but we see patients that we consider as uveitics, and we treat them as such. But Tom, what's your kind of stepwise approach for a lot of your patients? Do you migrate right to the intravitreal? Does it matter on the patient's diagnosis and approach when you decide on the intravitreal versus the topical therapy for your patients?
Yeah, I think, well, topical, you know, for anterior segment inflammation is the best. So I use, if there's any anterior segment component to it, I almost always use topical steroids as part, because it just reduces the amount of intravitreal or systemic therapy that patient may need. But you know, otherwise, I use a lot of systemics to control inflammation in the eye. There's systemic steroids and systemic steroid-sparing agents in patients who may need control over a longer period of time or have chronic disease. But I find that intravitreals, in my practice, are a very much needed augmentation to systemic therapy, because with a lot of times cystoid macular edema or even retinal vasculitis just doesn't respond very well to a lot of the agents that we have, systemic agents, whereas intravitreal steroids are fantastic. So I use Ozurdex in some situations, I use Utiq in other situations, and I use Retisert in other situations, and they're very different types of intravitreal steroids. But the Ozurdex is shorter acting, but the longer acting too, the Retisert versus the Utiq, it really is kind of sizing up the inflammation. Retisert is really the bazooka, the big power,
right.
triple the dose of a Utiq, and the Utiq is good for patients that have maybe a little bit less disease needed.
Mike, we have had intravitreal triamcinolone off-label for posterior uveitis for a long time. What are the pros and cons of this agent right now?
I mean, so the story is that, it's important to understand that, triamcinolone is easily obtainable and it's relatively inexpensive. But you do have to understand when you get into intravitreal triamcinolone, they had a black box warning against it. So, I mean, they had to have a commercially available product that runs from it. And it's interesting, I typically used to use triamcinolone. I used to use Subtenon's triamcinolone before I did it as like a stepwise approach. But the POINT study really made it really clear that you'll have significantly better response if you can put the steroid in the vitreous closer to where the action is. So the other problem for me for steroids is that for triamcinolone in particular, my patients see it. They see this snowball effect, this snow. So I'm sometimes I can't see anymore. I'll get this call like a day or so afterwards, or even that evening. And especially some of my pseudophakic patients or post-vitrectomy patients, I've got to deal with pseudohypopia and things of that nature. So I'm much more, if I'm going to go into the posterior chamber, I'm much more likely to use dexamethasone implant because I know how that responds because we've used it in other indications. And I don't have to worry about the patient worried about, is my uveitis really getting worse, or is it just due to the steroid I give?
Yeah, I just saw a patient recently that was sent in to me. You probably see these sort of things where you have migration of the triamcinolone into the anterior chamber, and that is
I hate that.
Almost the kiss of death sometimes because you have to then extract it, and they can have high pressures for a period of time. And not only is the obstructive issue there, but the triamcinolone can cause, obviously, itself, the pressure rise. And then now we have the fluocinolone acetonide intravitreal implant. This was a non-dissolving insert. It's non-bioerodible. It contains 0.18 milligrams of fluocinolone acetonide. It's a 25 gauge needle. It's a preloaded single applicator, and it has an indication for FDA usage. So, Carolyn, I just wanted to talk about sort of that approach to that. What do you tell? You train residents and fellows, and people may be watching who don't do this necessarily injection all the time. Is there any differences in how you do the injection for a patient with this applicator versus other applicators in the past?
Well, I think that it's important to try and play with the applicators, certainly with someone from the company or a rep or some empty applicators before you use one, so you get a feel for it. I will say that every applicator has its little niche-y kind of thing, even how you open the packaging. You want not to disrupt it when you open the packaging, and then you want to be very careful to inspect the device before you use it. Take the lock off. The one thing about this device is it has that the little accordion that you remove in order to have the medication.
It's called a trombone.
The trombone. Sorry, wrong instrument. Trombone.
Right.
Not an accordion.
Right, exactly.
Maybe an umbrella. But you take that off. Thank you, Tom Albini. And then you take that off, and then you have to be very careful not to manipulate the Utiq injector too much. But
right.
I mean, you would have to manipulate it hard. But with any implant device, I want to be the only one touching it. I want to prepare it myself. I don't want to, have anyone pressing all the buttons on it.
Yeah.
And then I think one thing that I really like about this is it's a 25 gauge needle. So, with some of the larger injectors, there can be some hypotony and choroidals after, which you have to be careful of. And then the other thing I would tell fellows or anyone who's doing these sort of implants is I am very meticulous about sterility before I give a steroid implant. I mean, I will put betadine on the eye well in advance. I will really anesthetize the patients. Even if it's topically, I want it to sit there for a long time, make sure they don't feel anything, and meticulous betadine use so they don't have any sort of, post-operative issues.
Mike, you did such innovative work on the applicator for dexamethasone and how it has a certain velocity in which it goes on. Can you talk about that a little bit and what that difference is in this implant, for example?
So the dexamethasone implant, we spent a lot of time, and actually, if you look at the dexamethasone implant and you take it apart, it is an accordion. So it actually, there is a direct correlation with how fast you push down on that button and how fast that implant comes out. And you don't really have a lot of control in that process, okay? We taught you a new technique by using your thumb and rolling it backwards to slow it down. As you go to the fluocinolone implant, you probably have a little bit more control with that plunger, being able to inject it, and you can inject it a little bit more slowly. I also want to piggyback a little bit off what Carolyn said. If for these people trying it for the first time, you're going to be, for lack of a better word, fumbling, getting used to it, because if you used other applicators, it's slightly different. I would start my patients, and I have on subconjunctival anesthesia. So as you're getting used to it, you're going to be able to do it, and the patient isn't going to notice as you're starting to getting used to the first couple of injections. Once you feel comfortable, yeah, you can use topical. But I think those two things are very important. And again, I don't think there is much. You don't have to worry as much that it's going to go as fast when you use this applicator as opposed to pushing down very hard on the dexamethasone implant.
Tom, you've used all these applications of these steroids, and tell me about more of the kinetics involved here. Do you see the same sort of kinetic fashion of release of steroid, the zero-order kinetics, or whatever the kinetic properties are of these drugs? Some of them obviously sustain, some of them not, but how do you kind of comment on the kinetics of these applications?
I think with the POINT trial, we've got good clinical data showing that the dexamethasone sustained delivery versus triamcinolone is very similar. So at least in terms of visual acuity, you see a much more rapid response than you do with subtenons, which was another arm in that trial. So we know that those are similar. I think that with Retisert and with Utique, you see a slower release and a slower effect. So I think if your expectation is that you're going to get the same type of effect that you would have with triamcinolone or with dexamethasone, when you inject this, you're likely to be disappointed. But the duration on the other end is huge.
Yeah.
The 3-year duration is great. But I think of this kind of as a chaser. I think that the first punch is really with usually for me Ozurdex or triamcinolone. We can debate about which one of those two, but I tend to use Ozurdex, and then you can follow up in a patient where you expect that this is going to be chronic with something like a UT.
Yeah, no, I think those are great points. So, Caroline, what are any contraindication to long-acting steroids in your practice? Where do you not want to give a patient potentially a long-acting steroid?
Well, I think that typically it would be someone who has, already uncontrollable glaucoma, difficult to control glaucoma. There are patients that I've, given shorter acting steroids to, but their pressure's controlled with topical drops. And, I tell them that if we use something like this, they will be on drops. And then I would say any patient who is just maybe really non-compliant, I would want to make sure that they would come in for intraocular pressure checks, and I wouldn't want to give this to someone and not see them for 5 years and have them come back with doubt.
Mike, how about you? What are the really contraindications to any of the steroid delivery options?
I think the longer-term steroid delivery options are people who have ACIOLs or aphakic. The concept of migration is definitely something that you have to worry about in these people. With the longer-acting steroids, they're smaller. They can get through smaller holes, so they can migrate even easier. And especially in patients who are post-vitrectomy, they move a lot more. So those are people I worry about. Obviously, everything that Caroline just talked about, IOPs, you just have to make sure that you're able to follow these people. We have an understanding, based on work that we've done with the original trials for Utique, when to come and see people. But again, I think it's important that patients are going to be compliant enough for follow-up, because obviously we want to catch the IOP increase early and control it with medication.
Tom, one of the other things is that we can't really predict the future, and glaucoma sometimes can happen. So is there anything you might look at prior to the patient getting the drug to say this is a patient who might be an IOP responder to steroid and therefore need to monitor him a little bit more closely? Are there any baseline factors or characteristics you can point out?
I think history of steroid response. Most of these patients, by the time I'm putting in a 3-year implant, they've been exposed to, at a minimum, topical steroids and probably some other form of local steroids.
Right.
So I look at what that response was, and if, I feel much more comfortable doing it. But I don't, to me, with all the different intravitreal steroid options that I have, and we don't have really great comparative data, I mean, I'm not as worried about glaucoma with this implant as I am with the other ones. Just my overall clinical gestalt is that the problem is certainly, we know, well documented, much, much worse with Retisert. But even with dexamethasone, my feeling is it's probably a bigger problem there with repeat dexamethasone injections. So I'm not that worried about pressure rise. I will take a moment just to say one thing as the uveitis enthusiast is rule number 1, rule out infection.
Yes,
so that's another thing, because a lot of times we don't get the FDA ABS, and you don't realize that's a real way to get in trouble. And the most common one is toxoplasmosis. So look for toxo lesions and make sure that you're not dealing with toxo, because a steroid implant could really light that on fire.
That's fantastic points. Tom, I think you're absolutely correct. Our glaucoma colleagues, who we also call the ocular plumbers of the eye, have come up with such amazing ways of taking care of patients now, between SLT and GATS and everything else. The armamentarium they have is so wonderful that they can really, if you need to use these, they'll figure out a way to use these. Really, they've been able to come up with this. Caroline, you talked on the optimal injection procedure, so I'll go to Mike. What's your optimal injection procedure for this injector?
So what I want to do, I'm really going to kind of piggyback what Carolyn says. This is, it's an interesting injector in that we have this trombone. It's important that when you take it out of the package, you keep it elevated once you remove that trombone, because you don't want that implant to inadvertently be released before you actually go into the patient. I usually inject it inferior and temporally, so I try to maneuver myself in such a way that I'm with that in the patient, because if the patient happens to bells, I'm not going to be running into trouble. I'll display, I put in betadine first and let the betadine sit for about 30 to 60 seconds after I did topical. Then I'll use a Q-tip soaked in betadine just to be super sure. Put it there for about 10 to 20 seconds. Displace the conjunctiva. I'm actually in this angle, and then I'll go straight down in, trying to aim towards the optic nerve, because obviously you are shooting it out, and especially in phakic patients, the last thing you want is to cause a traumatic cataract.
Yeah. Tom, I'll leave the last question to you before we get to our cases, because I promise the cases are going to be great and full of discussion. But what are the post-injection monitoring procedures? Do you see them 1 week, 1 day, 1 month? When is the good time to see them to assess both efficacy and potentially IOP response?
I think for this, it depends a lot on the extent of uveitis and the severity of the uveitis. I might see a patient back in a week, but not really because of the YUTIQ. It would be more just to monitor the disease. I think if the disease is kind of low grade and I'm comfortable, my routine turnaround time is about 6 weeks to see them in 6 weeks to measure the pressure. To see if they're having a pressure problem with it, but otherwise, I really have very little worry with this drug. I haven't seen vitreous hemorrhages, retinal detachments. It's very well tolerated, and I think 6 weeks is fine.
That's great. Caroline, any differences as far as follow-up goes for you?
Very similar, 4 to 6 weeks. Mostly to see if that's when the pressure goes up. And I usually expect to see a little bit of response by that time. It might not be a complete response, but.
Yeah, one of the ways that I've been able to use this in practice is nowadays with the pandemic. Obviously patients don't always want to come in, but they'll come in for an eye pressure check and an OCT and then leave. And at least then we can see with that, is the patient having some response? We don't necessarily need to do the whole physical examination, but at least we can do some parts of it and at least see that response.
And that's a great point, because the patient might not live close. They might live in New Hampshire. There might not be anyone close by, but there's almost always an optometrist who could check the pressure and do an OCT and get back to you about that.
All right, so let's start with some of our clinical cases. This is actually a patient of mine, female, 60 years old. Diabetic, but no history of diabetic retinopathy. She was referred to me after she had cataract surgery in her eye. It was her right eye that had this, and actually had a trauma to this eye. She had a head trauma from an airbag injury. She then had an epiretinal membrane, which the outside physician decided was significant and decided to peel. And then she was presented to me with persistent intraretinal fluid following the peeling. She had 2 intravitreal triamcinolone injections and was on Pred Forte 6 times a day for incomplete resolution. And here is her clinical examination. She's 20/40, 20/25 in the left eye. She has an IOP of 17. Her slit lamp examination shows this traumatic iris loss. You can see with the 3-piece IOL in the bag and an open capsule. We actually did a UBM to make sure that the IOL was in the right position. It was partially subluxated temporally with mild denesis, but she's avitric at this point, and her left eye is totally normal. Caroline, just in first thoughts, what do you think is happening here? What are your thoughts about what you do with this patient, or what you want to do with this patient from a diagnostic criteria standpoint?
Well, I think that, this patient might have some low-grade inflammation related to this IOL. The IOL might be rubbing on the iris, producing CME. The eye looks a little bit red, history of trauma. So I think it's great that you did a UBM. And then, if the OCT, which I think you're going to do, shows some macular edema, then the question is, do you approach the lens? Do you leave the lens and just treat the edema? Those are the options I would think about. It is a young patient, so you might want to do something that's a little more long-term.
That's very kind of you. She's 60 and she's young. No, I agree.
60's young.
60's young. They live for 25 to 30 more years, and so we need to be careful about that. You're absolutely correct. No, I agree with you.
Sound like an animal.
I
How old
think-
are you, Dr. Singer? Not
Oh, here we go. That's not nice. That's really not nice. So here are the fundus examinations. Not a significant amount of cupping you can see in both eyes. Here is the fluorescein, just showing you again, just mild, petaloid leakage in the macula, a little bit of a hot optic disc. Here's the OCT you can see for the left eye and the right eye. The right eye has some amount of macular edema. It's a post-peel looking eye. There's no ERM present now. There's a mild amount of edema, Mike. So what are you thinking about doing for this patient now, given the current state?
So, one of the things that is obvious to me is that I've got a problem because I lost my sync. In the process of removing the epiretinal membrane, I also took out the vitreous. So anything that's liquid-based is not going to last very long. And especially so at this point, and the other thing, knowing from what I've learned from the POINT trial, that I'm not going to get as good response for someone giving a subtenon Kenalog. I'd be much more likely to say, look, I'm going to try a DEX implant because I know a DEX implant isn't affected by the fact that there's no vitreous. That Barry Cooperman did some amazing results many years ago that shows that sustained release is sustained whether you have vitreous or you have fluid. So I'd start with that and see what I got and see what my next step is. And especially if the patient doesn't want to mess with the lens, because again, things I can do in the office, my patients seem to be much more amenable to than taking them back to the operating room, and especially someone like her who's already had trauma and had a number of surgeries. I would think she'd be a little bit more gun shy.
Yeah. Tom, this is not necessarily, the uveitis that we all deal with,
Sure.
but it's a different type of uveitis, right? It's anterior segment trauma.
I've
and
got
we
a
deal
lot of
with
these.
blood.
Yep,
Yeah.
yep.
So what do you feel like has been the greatest success story in you? Is it topical? Is it chronic nature? What do you feel like? Is it acute, or do you feel like these people ever get off steroid as they go along?
They can. I have a lot of patients where removing the lens because of the positioning, suboptimal would be a reasonable thing to do, but I don't because I can treat them medically and not have to put them through that surgical experience. So my list is I would add an NSAID, topical NSAID, and try that. I've had some success with that. This is a mild case.
Yeah.
I think you could stepwise try a number of different things. I might try a subtenon Kenalog in this, and I would go to something like an Ozurdex, and then if the swelling recurs, then I would do a 3-year implant.
Tom, can I ask you a quick question?
Yeah.
If you use an NSAID, how many times a day do you use it?
Like 4 times a day.
Right, because that's one of the things that I've noticed that when you get NSAIDs, NSAIDs are now been designed for cataract surgeons in mind, so their indications are like once a day or twice a day, and you may have to push a little bit on your pharmacy to say, look, we want this 4 times a day. The original studies done with NSAIDs showed that they really, in terms of getting to the back of the eye, they go through the sclera. They don't go through the anterior chamber and the cornea. So I think you really have to pound the amount of medicine that patient gets with an NSAID to see any results.
I think it's worth a try. I've had some successes. I was skeptical, but I've seen it work.
But the other thing is this young patient, has already failed treatment. I did catch that in the story. I already failed treatment with drops. And
Yes.
6 times a
This is
day.
why this patient was referred to. I mean, you can treat this short term. You might also sometimes try a dilating drop can help. I mean, maybe not forever, but just to get them past this episode and make sure that you can get the edema gone.
Right.
And then if you get the edema gone and it comes back, then you can say, okay, we got it, we made it go away. Now we might need to give you something longer acting or do surgery to make that a permanent situation.
So we had all of these discussions with the patient. She was very tired of all the things she went through, the ERM surgery, which she is not sure wholly necessary because the edema was there and the ERM was there. So the surgeon tried to make the idea that maybe this was a combination of traction versus inflammatory components. It's really hard to tell. I don't fault the surgeon for that necessarily. Actually, that's some of the things we all deal with when we deal with these in practice. And topical therapy was becoming a compliance issue. And one of the things I left off with her is she actually had rheumatoid as well and had difficulties with her rheumatoid in her hand that was there. So this might be a little bit of an inflammatory reaction from rheumatoid. We've seen rheumatoid uveitis, and that can certainly cause that as well. And certainly this might be the whole picture of her. So given all of those circumstances, we actually decided to go with a longer acting steroid. In this case, it was the fluocinolone implant. And the reason I went that way was for two reasons. The first was I could assess that the intravitreals did work. She brought in OCTs that showed she did have a response, so there was a good response, and she did get better vision. But at the same token, she didn't have the beautiful, the IOP rise I was most concerned about. So as a result of that, I was able to give her the single injection here. This is baseline 20/40 visual acuity, 17 on the right eye, 371 CST. 2 months afterwards, she's 345. I think, Tom, you brought the great point of is that the kinetics of this are a little bit different, but you see a nice modest improvement in the CST over time. Visual acuity improves. This is now 12 months out, single injection. She's 20/25, 330. She's incredibly happy. And this is actually the graph over the time. And I just saw her a couple weeks ago, and she is just ecstatic that this has worked out. Now, granted, this might have occurred with any steroid that's a long-acting steroid, but clearly there's still an effect here, and she's still having a wonderful effect without much intervention. She's not on any drops right now, and actually, sure, IOP didn't rise, thankfully. And I think, again, we saw that benefit of the drug in this case. I just thought I'd point out, did you have a comment about the case at all?
No, I just said great case. No, I mean, I think you can't argue with success. So it worked, and it's
Yeah.
great. But yeah, some of these patients may respond to shorter acting. It's
Yes.
hard to tell.
Yeah, absolutely. Just to point out some of the results from the fluocinolone acetonide trials, that the time to median recurrence was about 1,051 days, which is incredibly long duration. I think that's the longest duration we've seen. We know that Ozurdex and other steroids are really shorter in duration. This is versus the sham treatment in this case. And looking at some of the cumulative recurrences of the study, you can see the recurrences per eye in the study, which is a 3-year study, was only about 1.2 times. So really low rates of recurrence to this, and you can see the breakdowns of percentages. So high numbers of percentages, less than 0 to 1 times. Almost 43% were a one and done type of patient. So that's a really great potential outcome for this. And let me show you this. Okay, great. So
I have a quick comment,
Yes.
Rishi. I think that was a great case. And one thing that you said, you saw she had responded to triamcinolone, but sometimes I've noticed that patients may not respond to one type of steroid implant, but they might respond to another. They're slightly different. The release is different. So it does make me feel better if they respond to something, but if they don't or they only have a partial response, it doesn't make me stop from using it. I'm wondering how you feel about that.
no, I think you're absolutely
experiences
correct.
with
I think that there's certain types of steroids people certainly respond to. Giving a trial of this, and as I did monitor them every 2 months, was why I was trying to do that, because you're right. This patient hadn't been exposed to fluocinolone before, had been exposed to triamcinolone. That doesn't always mean it's the same drug. And so it's really important to assess that response. And you saw the kinetic response, which is what I was watching to see what the CST value did and what there was, because there's no overt cell and flare in this case. There's a low-grade inflammatory component here, which we're following, and that's all I can really do in this case. But you're absolutely correct. There could be patients that respond to those dex versus fluocinolone.
So this patient got intravitreal triamcinolone and did not respond, the CME?
No, they did.
Oh, they did.
But they did.
It came back.
But the point was, I think Carolyn's point is well taken, is that does triamcinolone response mean fluocinolone response? I usually think it does, but it's not always the case. It's not 100%, but it's worth exploring.
Or if they don't, if someone doesn't respond to triamcinolone, they can still respond.
Well,
yeah,
I think
That's what I was.
cystoid macular edema is probably going to respond to intravitreal steroids. It's pretty rare that it doesn't. But I would think that it's more likely to respond to triamcinolone or dexamethasone versus YUTIQ.
Right.
So I just think that those are stronger. At least that's what I've observed in clinic. And the YUTIQ, just doesn't have the same bang, but it has a much longer tail.
Duration.
Right.
Right.
And
Well, and for good reason, maybe that's something that, like you said, it's a chaser.
Yep.
Mike, this is your case?
So this is an interesting case because life is a little messy, and it doesn't always give you one diagnosis at a time. So it's a nice 31-year-old female, and again, I'm going to pass on the diagnosis for a minute, but I'll just talk about the fact that she comes in and she's got some changes in the back of her retina, and you can see she comes in and she looks like she's got some leakage on her fluorescein angiogram and obviously fluid on her fundus photography, and she's a high myope, and this is her OCT, and you can obviously see there is some subretinal fluid, and typically, if any person in the panel, what would you typically do if someone walked into your clinic? What would you give them?
Well, I would get an OCTA just to confirm.
Let's assume we're in in the we're in the outskirts.
You don't have an OCTA?
I do have an OCTA. But not of all our viewers may have an OCTA.
So are we in Austin compared to San Antonio? Is that where you're talking?
No, we're in Del Rio, Texas, which is 150 miles away. Okay. And we're the only provider for 40 years. Keep going.
Anti-VEGF would be the option, I think.
Yeah.
But you're absolutely correct. I think OCTA or fluorescein angiogram would help you probably in this case.
Right. So we gave her ranibizumab, and she got better, all right? And, so now you look at this, and you look, there is obviously still a window defect from what has happened, and her vision's good. But again, you're having this now as her baseline has changed, right? She had a totally clean retina. She has an area of, what we would consider wet myopic degeneration with neovascularization. She gets her medication. She looks good, nice OCT. She comes in on the 18th, though, of March, a year later, and this woman seems to have a tendency to show up just when there's a problem, not when things are going okay, which is like most of your patients, right? She comes in, and now I see this, and now I've got a second lesion. And it doesn't kind of look, and if you can look at the color photography, it's the bottom lesion is significantly more yellow. Doesn't pick up as well. And I got this hot spot. And obviously, I've got the atrophy on top, and that's not acting up. It's really only the thing on the bottom that she's really noticing, and she notices a superior scotoma in her vision. So I'm trying to figure out what's going on. And to be really honest, when you're in trouble and you have a question, sometimes ask your friends. Okay, you've got friends in the community.
So we have some friends here. Let's ask them.
Exactly what I was going to say.
Why ask your friends on the phone?
Am I still your friend?
I set him up perfectly.
So Tom or Caroline, do you want to comment on what you think is happening?
Well, I'm going to comment first, but the nerve is hot on the fluorescein, and so what is the etiology of this choroidal neovascularization, and that a lesion appears now, and that is really not typical of myopic choroidal neovascularization. So this could be an inflammatory etiology. And in the old days, before anti-VEGFs, actually when people had idiopathic CNV or inflammatory presumed in a young person cause of CNV, we would put people on oral prednisone or give them a steroid injection into the eye. That's kind of really old history. And so that might be what I would, consider in this. And it almost looks like infranasally. There's a little bit of leakage or vasculitis there, and there's a white spot infranasally too. So, and I would do a uveitis workup. I'd call Tom, and I'd say, hey, what should I do?
Hey, Tom.
I think that's perfect. The only thing I would add is that what you have here is really sight-threatening uveitis. I think now because of the second lesion, I agree. I'd be more suspicious that this was an inflammatory condition, like a punctate interchoroidopathy with new lesions coming up. And I think here, long-term treatment makes sense from the uveitis point of view in terms of this being very, potentially sight-threatening, and she could really lose the vision in this eye. So here you have what seems to be, at least up until now, a totally monocular process. We have no evidence that there's anything going on in the other eye.
Right.
So I think a long-term steroid injection makes a lot of sense. I also agree that we've graduated from triamcinolone monotherapy for these to adding in an anti-VEGF on top of it if the CNVM is acting.
That's a great point. One thing I'll add, I think, from the imaging standpoint is fundus autofluorescence could really help you here, because I think you're missing lesions. Maybe we missed them in the first photograph, but sometimes an FAF can actually really help localize these, I think, bring them to the forefront, because I think these Optos images always here, it's the red-green channel thing where you're missing some of the coloration, the real true color images, and so we might be missing some of the lesions, at least early on.
The other thing that's really good for that is ICG.
Yep.
So
But again, given the fact that, and again, it's not making excuses. I'm trying to explain to everyone that in case you don't have all these high-tech pieces, they become an issue. Because, interesting, the Optos camera we had then, turns out wasn't able to do autofluorescence at the time and couldn't do ICG. It was the older version. But yes, you're right. You get more tricks. And again, to your point, the sight-threatening nature is what really got me nervous. And again, to be honest, I didn't have all my experts to the right, but I did call other people to say, look, had you seen this before? And we started them on triamcinolone and ranibizumab and oral prednisone. I kind of shotgunned it because she was really panicked, although I wasn't sure what was going to happen. And
so is this what do the panelists think? Is that something you would do for this patient? Is it steroid alone or anti-VEGF in this case?
I would do combo.
Combo, yeah.
Combo.
I would do combo. I'm not sure I'd put on oral, maybe, but probably short dose like you do.
My feeling was just right, yeah.
Right, but yeah, definitely, I think that's one of the benefits of, it depends if both eyes are involved or just one, but one of the benefits of giving intravitreal steroid is the rapidity of action.
So this is the OCT. It's not really hot. It's there. You can see a little bit of cystic spaces, but her visual complaints were significantly worse than the OCT suggested. Turns out I now start to see trace cells, believe it or not, in the front of her eye. But that lesion is no longer leaking on fluorescein angiogram, and it's only been about a week. Okay, but I did throw the whole kitchen sink at it. She does have IOP issues, though, right? So life is messy. So what would you have started on? How would you deal with that IOP? Does 30 worry you enough to call your glaucoma colleagues, or can you handle it by yourself?
Well, I can handle 30, but I think I can handle. But 30, I tell the residents and fellows, never let someone leave your office with a pressure 30 or over. You really have to get it up, and the teaching is that 30 or up, you're at risk for a retinal vein occlusion. So you should have the pressure below that.
And I think in this case with a patient, moderate cupping, you probably could handle it yourself, as you mentioned as well. In addition, I would say to you that the idea of starting them on both an aqueous suppressant is a great idea. That's where you really want to be with steroid-related IOP rises, is both with an aqueous suppressant and both using timolol and the carbonic anhydrase inhibitor are the way to go with this. So good job with that.
Well, thank you. It's as typical retina surgeons, I have a high pressure. I want to get this down with every mechanism of action I can and get it down soon. Exactly to Carolyn's point, because I do worry about potential retinal vascular occlusive disease when you have really high pressures. Okay, so now we're moving along. So the pressure's still 29, and sometimes the reason the pressure's 29 is you do a history and realize she didn't pick up the drops, right? Again, you have to deal with what you got. So it's interesting. I do have so you can see here, but turns out she is deep and quiet. She's got RPE changes that are minimal. We didn't get a fluorescein angiogram on this day. The OCT looks a little bit better, but I give her a bottle of Cosop and say, take this, and hopefully that helps. So now she comes back a month later, and now her pressure is 14. Things look very good. She has a little thing that may be acting up, and she's a little more symptomatic. And down below on the arcade, you may start seeing a little bit of it lighting up. And I also thought maybe it was a little hotter in the original myopic lesion. Okay.
This is so hard. So, Tom, do you have any thoughts on how you look at neovascularization in the patient who has this sort of setting? Is it
You know, I really think this is, I hate to say it again, but OCTA is fantastic.
We are in Del Rio. We don't have OCTA.
But if we don't have it, then you got to make, I mean, fluorescein is very tough to interpret because the inflammatory lesions also can leak.
Yeah.
And so it's tough. I mean, you try to make the best decision that you can make. But I think that I would err on the side of treating with anti-VEGF and steroid of some sort, either systemic or intravitreal, or both. But so I think everything that's been done here is great. You know, the one thing I'll say is that most of the time you don't need a lot of anti-VEGF injections in these eyes. So it's usually just 1 or 2 or 3, and you're done. It's certainly not like AMD where you're going on. So I would do 1 or 2 or 3, anti-VEGF.
And that's, so I started looking at this, and I planned on ranibizumab and bring her back in 2 weeks for dexamethasone. I did notice that the nerve was slightly hot as well, which kind of made me feel, well, maybe, I'm still dealing with potentially 2 problems at the same time. I did give her, she comes back, she's 20/20, we're still at high pressure, so again, I stress compliance, and the compliance, basically, we try to get her even to 3 times a day to control the pressure. I'm going to keep, finally, if we get the pressure under control, the lesion looks a lot better. We got 20/20. We really have given her 3 medicines, so she's a pretty hard to control person but the steroids are obviously doing her good. She's much less symptomatic. She seems pretty happy about the process. So now a number of months have gone by, and I'm thinking I want to be able to control her better. So we're giving her dexamethasone implant. We had been playing with that, and now we've gotten 3 months of efficacy. We're able to control the pressure.
I think the vision is 20/20, right? Or is
No, now it's 20/20, so she came back.
Oh, okay.
So she was 20/20. She came, again, every time she comes in, typically it's emergently.
Yeah.
So now she comes back, she's 2200. But to Tom's point, at this point I had thought to myself, it really isn't likely to be as VEGF mediated as inflammatory mediated.
Mm-hmm.
And, so I said, even though for 2200, we're going to go the other way. I was going to give the dexamethasone first and see what happens and see if I need to do ranibizumab. And I gave her dexamethasone, and suddenly she went from 2200 to 2030. I do have a little bit of leakage on the fluorescein angiogram, but what made me feel a little bit better is the nerve is not so hot anymore. Because again, that was giving me an idea that the inflammatory process is not there, and this may end up being a window defect below, not above, that I may just be having to deal with. She is finally taking her COSAP 3 times a day, so I feel better about that. Now I'm giving her dexamethasone implants about a 3 to 4 month cycle. We're watching to see what happens. So we go for a while, we do this, she's doing good. She comes back and say, look, I need to probably do something more chronic. She also switched insurances at this point. I'm able to get her fluocinolone because I thought about it earlier, because and to be honest, I didn't want this nice lady to keep showing up at my doorstep emergently because her vision went down. So we put her on fluocinolone in November of 2019. This is the day, so finally I get her when she's not as acute, having increased fluid. We then see it 1 month post the implant, pressure still holding relatively well, 20/20 vision. We got a little debris. Finally, she had manifested a little bit of debris, and so I knew I was treating an inflammatory process, but it's not affecting her center vision. She's 20/30, she's doing fine. This is 8 months. Now, this lady had a lot of steroids. And we have to understand that we have a lot of steroids. Typically, you end up with cataracts. How often, so basically, we're looking at, this was about almost 18 months. How long in your experience do you typically expect to see cataracts when you start people on these steroid regimens?
Depends on the dose, and, I would say that probably, this woman's she had 3 dexamethasone implants, and I think that is good timing to see, 1 to 2 years, you're going to see some cataract in these patients.
Yeah.
Also, she has uveitis too, which also increases cataracts.
And I think this is actually a very common part for the course. 18 months is what they saw in Protocol I for steroids and DME. So you're right at the right course level.
I mean, obviously, you can see the pictures out of focus, and it's poor view. And at those days, we had a PAM, a potential acuity meter, for people in the audience to help us give an understanding of that there's potential improvement. She's got a significant PSC. She gets cataract surgery, and voila, she's 20/20. She's doing all right. The lesion isn't really bothering her at all. OCT looks relatively good. We're now 11 months, status post the fluocinolone implant. We're now 1 year out, 16 months out, 17 months. She had come in for something else.
Can I just make a comment?
Yep.
Like, this woman, if you hadn't treated her locally or intravitreally with steroids, she would be on oral prednisone and maybe
Yeah.
immunosuppressants. And maybe she doesn't like to use the glaucoma drops, but I think you saved her eye by doing that. I mean, being on oral prednisone is for 20 months would not be fun, or an immunosuppressant. Tom, what do you think?
I use a lot of immunosuppressants. Sometimes you have to, but I think here it's a fantastic outcome with saving her, even methotrexate and serious drugs. This patient had rheumatoid arthritis
No,
also?
no,
it was
she's
another.
totally.
So I think it's a fantastic way to treat it. The other comment I was going to make was that it's also helpful for the cataract surgery to have a steroid implant in the eye to keep things quiet around the time of surgery, because you worry about the uveitis reactivating. Not that I think in every patient that YUTIQ is going to be all you need to keep them quiet through cataract surgery, but it's certainly very helpful. And how much steroid you need to keep them quiet perioperatively is more of an art than that we don't have really great guidelines on that. But I kind of size up what I think the risk of problems are and sometimes use oral steroids. But here it was clearly enough, and it worked fantastic.
And she was 30s, right?
Right,
Childbearing age.
that was
doesn't have to go-
definitely a factor. We had this discussion about, once we started systemics, and then she wanted to get pregnant. So
Oh,
this
yeah.
definitely was in the
Saved
process.
her eye. That was
I would definitely, one thing to say about this is watch the other eye very carefully, because these tend to be bilateral. They can be unilateral, but just make sure that you don't miss anything brewing in the other eye. But it's great.
Keep going, actually. So this is actually a slide that shows you from the phase 3 study of the fluocinolone acetonide implant, what the rate of IOP lowering medication was. It's actually 42% in the fluocinolone acetonide implant group. And IOP lowering surgeries were up 5.7% again in this study. And again, interestingly enough, this study was investigator discretion with regards to how they handled the IOP. So I think sometimes, some people are more cavalier and try tubes and things like that, versus others may do the topical medication route and potentially systemic route for those patients, or local route to take care of those patients rather than doing this. And again, the cataract extraction rate, as Mike had in this case, just point out that was 73.8% in the group over a 3-year period of time, so a very long period of time we're talking about here with regards to cataract extraction in these patients who had that.
So looks like I get another case.
Yep.
So, that was a little bit more of a zebra, right? This is a little bit more things you're going to see. And again, I'm a retina specialist, so this is things that retina specialists are going to get. And essentially, this is a patient who comes in with, 71 years old, much older patient, has CME, low-grade vitritis, had come in from another doctor, had 8 dexamethasone implants that lasted less than 3 months, and essentially, but came in and said they're having problems seeing. This is their only eye. The vision's 20/60. It really is a problem going, and we need to do something. They were on topical steroids, though you don't see that in the process. So I said, look, it was working. She hadn't had one in a while. He hadn't had one in a while. We gave him dexamethasone. This is the initial presentation, so I kind of jumped to the treatment before. You can see the low grade, the more chronic looking CME over time, but the OCT is pretty dramatic. We gave him one shot, because I wanted to get I needed to get them controlled. And this was 4 months pre-fluocinolone implant. So he's 27. He had 3 months ago. I gave a shot, and you can see that basically comes back. So even in my own hands, not that I doubted it, but you still see people having swelling. In this situation, we said, look, we probably need to do something to last longer. So we gave them fluocinolone. There is a little bit of inflammation with cells and flare, and it's, but the vision has gotten better because they got a little bit of a dexamethasone implant on board. So you can see I gave him dexamethasone 6 months before, after fluocinolone. 1 month, everything looks dry. And basically see them over time. Pressure's good. when watching them. And the interesting thing is, it's really nice, some of these people that come in, if you know they really haven't had response to lots of dexamethasone in terms of IOP, you can feel a little better about the fact that you can follow them going forward. But I've been following them every month because they're monocular. They're 20/40. For the sake of time, I'm showing you the same pictures. We start them back. The trace cells is bothering them a little bit, so I do use a little bit of the Pred Forte to try to control it. Actually, one of my anterior segment colleagues actually saw them and felt bad about didn't have the chart, so that's why they put them back on Pred Forte twice a day. And I'm now chasing cells, but we do it 4 times a day. But the retina is staying flat. I mean, even though they have some small amount of mild to AC inflammation, the fact that the fluocinolone implants in the back, it doesn't seem to be affecting the back of the eye at all. So this is 14 months. They might have a little cells. They may have a little bit of epiretinal membrane, but we're now finally tapering this nice patient. And then you can see on 6/25 and 7/1, 15 months. And again, steroids in the front and the back, and yet they have, they really don't have any significant IOP response.
And what was the etiology? Is that unknown? Do you
It's
ever
unknown.
worry about things like lymphoma in a 71-year-old man and, with this sort of,
I do.
as the
I
underlying
do.
diagnosis? Or?
I do. It was one of those situations where the closest thing I was going to get to this person have surgery was putting a needle in their eye. But I did order a CT. I did refer them out to see if I wasn't missing stuff. But they weren't going to, on his only eye, there was no way he was going to let me do a vitreous biopsy. It wasn't up for discussion under whatever it looked like. But I was thrilled that he came back. He's happy because he sees he's now 22 months out. And what's the point of this case is to show that it lasts in certain people a really long time. We're at 23 months, 2 years, 25 months. So the good news is that, for him, who had literally eight dexamethasone injections who kept coming in, this medicine seemed to do very well for him. And to be honest, if he was a bilateral, if he had both seeing eyes, I don't think I would have seen him as often. I think it was because it was only eye, because I knew he wasn't having an IOP. We wrote, looking at fluocinolone in terms of IOP response, they fall into buckets, and usually if they're not going to have it early, every 3 months would be a typical bucket. But because it was his only eye, I was much more paranoid.
I think that's a very good use for this drug, and I have a patient that this reminds me of who's got bilateral cystoid macular edema. We don't he doesn't have vitritis, this other patient, but he just has recurring cystoid macular edema that one of my partners was treating for years. He was getting triamcinolone injections like every 6 weeks, every 2 months, and this was going on forever. And I gave him bilateral UTICs, and it hasn't been a home run. He hasn't been completely quiet, but it's drastically reduced the number of other injections that he needs. It's gone down from, whatever that was, 6 to 7 a year, down to maybe 1 or 2 a year. So I think that's a great use for this medication.
Yeah, great. All right, we have time for one more case before we finish up. This is a picture is worth 1,000-word case. This is a patient who came in to me. This is their OCT. They're an 84-year-old retired internist. He actually had surgery with an outside physician for an epiretinal membrane peel in this left eye. It says epiretinal membrane left in the right eye, but actually it's left eye. No other significant ocular history. This was their post-op picture. So they had macular edema. They have 2 macular holes. That is present there.
Before.
You have?
I've seen it too.
Yes.
This patient?
Yes,
No, you haven't seen this patient.
No, but I've seen the
Okay, all right.
double
The
macular hole.
holes of eye.
Oh, all right. Oh, so I thought I was. I posted like a hump day picture on Instagram.
That only happened after the surgery.
Yeah.
Yeah, that's right. Yep.
So this patient had been treated with diphenhydramine ophthalmic solution, BID to QID with an IOP rise, and no improvement in visual acuity. The patient's incredibly frustrated. He's a very active internist, actually, a active individual, although being retired at this point. And he actually was on dorzolamide, BID, and it was stopped. His pressure was 21 on presentation. He's 20/50 in this eye. So what are your thoughts?
It's
Caroline.
amazing vision for
Can you
that
just-
OCT.
He was on dorzolamide for glaucoma, or someone
For the
for
glaucoma.
the macular hole?
For the glaucoma
Closure.
response to the Durezol.
I see.
What do you want to do with him?
Well, I think that.
Take him back and peel his ILM and do a double flap here, or?
Well, you know, this is a double macular hole has been reported after macular hole surgery, an eccentric macular hole.
Right.
You only have to close the foveal macular hole. You can leave the eccentric macular hole.
Great point.
Well, I think you're probably going to tell me that you gave steroids, but I would.
No, but I think
I would think you need surgery to close the central macular hole or some sort of.
So it's not central.
I wouldn't touch this eye.
not
but
central.
20/50 vision. And
It's
not
eccentric. So
central.
the macular edema is in the central fovea.
I think
Right.
surgery's out
Those
of
are
the
eccentric. So
question.
you actually got it right.
Oh, okay.
You got it right.
Yeah.
So surgery's out of the question, I think.
Yeah.
So, so if you want to treat the macular edema, I would have to treat the pressure and give the patient steroids.
Right. Right. So what's your stepwise approach here, Tom? Topical, intravitreal?
Yeah,
what do you think?
that's the same that I said before. I would start with topical just to see
Yep.
how it responds, give it
Yeah.
a couple weeks. If that doesn't work, I still use subtenons, I'll admit it, even though it's unpopular. I would try that, then I would do intravitreal, and then if it recurs, I would do a
Right.
UTIC.
So I did just that. I did exactly that.
Okay.
And these graphs will show you all of that in one. So in the left side, you see my first picture when he first presented. You can see that on the bottom, this is from our EMR system. You can see how the drop there signifies when I started him on the drop therapy. That was in January of 2020. I treat him for drops for about 2 to 3 months, as you can see. I didn't get much of a central macular thickness response. So then I decided that at that point, I'm going to start an intravitreal therapy. I did a dexamethasone implant. He got that at that next point you see there. That's that yellow injection-looking figure icon. He then has a nice improvement in the retinal thickness. And now he comes back in December of that year, 2020, and with recurrence of the macular edema. So the third frame you're seeing actually is, the second frame is the last 2 images, and the third frame is the last image there. But basically, you see the macular thickness map is matching what I'm talking about here. And the last treatment he got was a fluocinolone implant, and this was actually his response. And so he had a nice improvement in his macular thickness. That was actually his last visit with us in 2021 so far, which has gone well. This is actually his IOP rise in that eye. So you can see that he did have an increase in the IOP, which was treated again with topical therapy. In this case, he was on COSAP. He only had that one rise. He's been well controlled on COSAP the entire time, and he's done really quite well. And his visual acuity, just to give you a sense of what he'd improved to, he actually improved to, I don't think I included it, but he included 2030 actually at the end of the day. So
Amazing.
so
Another
nice in
save.
response.
Yeah.
Yeah,
Another
so
save.
great. So wonderful. So I want to thank everyone again for watching with us virtually, and thank you those who are watching in person. It's our pleasure to give you this talk today on non-infectious uveitis. For those watching at home, please make sure to go and fill out the CME questionnaire for the credit, and we'll be happy to mail you that program evaluation as well as the credit at the end of the program as well. So thank you again to my panelists for this program, and thank you all for watching.
Thank you.
Thank you.
Great.
Yeah.